The biggest event in STEMI interventions in cardiogenic shock, probably even in PCI, has been the work of Dr. Holger Thiele. It's a absolute privilege, Holger, having you back at Lumen Global.
Thank you.
And on a personal note, first of all, I know you're expecting a child. Our best wishes, and
Thank you.
it's been such an honor having you at most of the Lumen meetings, particularly over the last few years. You had taught us so much more, but now you have the backing of possibly one of the most transformational trials. Take me first of all through the trial, and of course first we want to learn about the trial, and then there are several follow-up questions. I think it's going to completely change the way we take care of patients with shock, and I think the guidelines are going to be changing. And for all this most amazing work, my utmost sincere compliments to you, and congratulations for this fantastic work.
Thank you. So, yeah, when we are talking about culprit shock, so we know that roughly 80% of patients with cardiogenic shock present with multivessel coronary artery disease. And based on this, nobody knows on how to deal with these patients and how to treat these patients. So we know that we have to open the infarct-related artery, but we don't have to. Currently do not know how to deal with the other lesions. And if you look into the guidelines, so the ESC guidelines currently say you should treat and do PCI on all other lesions.
And the ACC and AHA guidelines too.
No, the guidelines itself, they do not mention it, but the appropriate use criteria, they say it's a A9, which means it's appropriate to do PCI on all the other lesions.
Right.
So this is what current guidelines say, and both guideline recommendation or appropriate use criteria recommendation are more based on pathophysiologic considerations, because there are, to be honest, nearly no data on this. And if you are looking into the data, currently we only have registry, or we had, until recently we only had registry data. And most of the registry data were saying that if you do immediate multivessel PCI, you have an increased mortality. Based on registry data, we always have to be cautious, because registry data are usually prone to bias. And that was the reason that why we said, okay, we want to do a randomized trial, we want to solve this open question on how to treat these patients with coronary multivessel artery disease in patients with cardiogenic shock. This is what we did in culprit shock. Altogether, we randomized 706 patients, which means now that this is the largest randomized trial in cardiogenic shock performed so far. And we randomized them to culprit lesion only, plus, which is important, we allowed possible stage revascularization, which is also totally different from all the trials that have been performed before in STEMI patients, where usually it was culprit lesion only, and then if you have performed stage revascularization later, this was counted as negative result within the primary study endpoint. But we said, okay, it's culprit lesion plus stage revascularization, culprit lesion only plus stage revascularization. And the other arm was immediate multivessel PCI of all relevant lesions of more than 70% diameter.
Which is what almost everybody felt was the right thing to do.
Yeah, and what also the guidelines said. Right. So we randomized these patients, and our primary study endpoint was 30-day mortality or the requirement for renal replacement therapy. And this trial was significantly, this trial showed that this primary study endpoint was significantly reduced with the culprit lesion only strategy in comparison to the immediate multivessel PCI strategy. And also for our surprise, this combined primary study endpoint was mainly driven by a more than 8% absolute reduction in mortality. It was not the renal replacement therapy. Renal replacement therapy had a p-value of 0.07, so it was not statistically significantly different, although there was a trend also towards more renal replacement therapy in patients undergoing immediate multivessel PCI. But it was mainly driven by an absolute reduction in mortality, which was also, to be honest, a surprise for us to see these results at 30-day follow-up.
So in some ways, with or without shock, management should be mainly focusing on the culprit lesion, no?
Yeah. So this is maybe the take-home message. Keep it simple. Just do in the immediate setting, just do the PCI, primary PCI of the infarct-related artery, and leave the other lesions as they are. And you can do, when the patient has been stabilized, you can do or treat the other lesions. This is what we have learned from culprit shock.
Right. So, and you know, look, there is your data is so powerful. It is so convincing. It makes so much sense. How, when you look at it historically, how did we start feeling? Where did the concept come in that, you know, for cardiogenic shock the approach has to be different? Let's fix everything.
So this is what I mentioned. So why probably also the guidelines say it. We believe that a patient with cardiogenic shock, he has severely depressed left ventricular ejection fraction, and he often is, even if you do the PCI of the infarct-related artery, this patient is ongoingly in persistent cardiogenic shock. And we want to do something. This is what we want to do. And that's the reason why we believe, okay, if we do PCI of the other lesions, then we can improve perfusion, we can improve the possible myocardial recovery. And that's the reason why we said, okay, we have to do it. But in the end, it doesn't work.
Which is the purpose of, you know, in my mind, that there aren't as many recent trials with such a tremendous impact. Where do you think are the guidelines going after your work?
This is, if you ask me, I can only speculate.
I understand.
Currently, at least in Europe, we will have the upcoming new ESC revascularization guidelines, which will come up in end of August or in the beginning of September. They're currently working on it, and there are two options, what I believe, when they take this trial. So first of all, they can give the recommendation with, maybe it's a class 1B recommendation to do culprit lesion only PCI.
Right.
On the other hand, they could also do it on the other way around. They could say, okay, it's a class 3 recommendation to do immediate multivessel PCI. I don't know how they will come up with a recommendation.
Between the two, there is a difference. One is showing you the positive way. The other is saying, look, that's totally wrong. Which one do you favor?
If you ask me, I would favor the class 1 recommendation.
Would they be asking you, or just your work?
No, so it's a guideline committee. They do it on their own. I have no idea what they want.
Got it. Got it. And I completely agree. I think going with the 1B or whatever is the way to go. Now, dealing with the vessel is just one part of it. No, we still have a patient with the impaired LV function. How do you take care of the mechanical support? Not that, I mean, to me, till you did this trial, your previous work was almost the standardized and the best guideline as to how to manage patients with shock. So what is the approach there now?
Also a difficult question, because we have not much data on this. So we have learned also from our so-called IRBP Shock 2 trial that the intra-aortic balloon pump failed to show a mortality benefit, or also if you look for the secondary study endpoints, the intra-aortic balloon pump had no effect at all on lactate, on doses of catecholamines, also on blood pressure, or any of the parameters we were looking for, also for renal function. So this is, at least for European guidelines currently, the reason why the intra-aortic balloon pump has a class 3 recommendation to be used on a routine basis, which still means that people are still believing in the intra-aortic balloon pump, that they still can use it. Although we have no data in which subgroup the intra-aortic balloon pump may work. Now, I think this is a reflex. We now have seen that the intra-aortic balloon pump does not work. So the reflex is now, okay, we have to do something. That's the reason why we are now going to more active and more aggressive mechanical circulatory support devices. We have seen a steep increase in the use of ECMO in Germany, which is partly based on the results of our IRBP Shock 2 trial, but it may also be partly attributed to reimbursement issues. You probably have the same in the
Absolutely,
United States.
same challenges.
The numbers go up. And if you look for the data for active devices,
Right.
there are currently only 4 randomized trials on this issue with active devices, with the impeller or with the tandem heart, but all the results are, if you are honest, neutral. Yeah? They haven't shown a reduction in the mortality for patients with cardiogenic shock. What I personally believe, we need more data. We need more randomized data on this issue. I personally believe that patients have a benefit from active devices, but the major question is the proper selection of patients.
And
this is the
whether
most
any
important.
subgroup would benefit.
Yeah, as you probably know, so in the United States there's currently the approach on putting an active device as early as possible. It's from the Detroit group, so they have shown in registry trials that the mortality is going down to 15 or 20%.
They've also started a recent registry which is going to be monitoring almost every patient.
Yeah, but if you ask me, so
That's not enough. You need
that's
to
not
have
enough. You have to
yeah.
do randomized trials. So currently there's one ongoing trial in Denmark. But they have problems in recruitment. We need more data on this. And then there are currently 2 initiatives also in Europe, and within our German network, we want to do a randomized trial on ECMO use in patients with cardiogenic shock. Our trial is currently, so we just finished the study protocol. We want to include only high-risk cardiogenic shock patients, which is difficult to define. What is a high-risk cardiogenic shock patient?
Anterior wall definitely involved.
We believe more in lactate. Yeah, so if you look for this, so elevated lactate, we looked into our database. Now we have more than nearly 1,500 patients in our database with cardiogenic shock. So lactate is a very good prognosticator for these patients. So patients with lactate of more than 3 have a mortality of more than 60%, which is a high-risk group. And that's the reason. This is maybe also one of the reasons why all these trials failed, the previous trials, to show a benefit, because they did it black and white. Cardiogenic shock, even the so-called low-risk cardiogenic shock patient got an active device. But if you have a patient who will survive without any device, the device can't show anything. And this is probably the major issue for these trials, to do the proper patient selection.
It looks, Holger, to me that there is a different approach in Europe and of course in Germany, with a far greater reliance and use of ECMO, which again, as you mentioned, is going to go through a randomized trial to demonstrate. In the United States, Impella has just jettisoned into a far greater use, and as you mentioned, with the recommended approach of putting in an active device, or Impella in this case, as early as possible. I agree with that, as early as possible, completely. Many years ago, I used to always recommend that when you're starting a procedure, first give attention to the support, and then you worried about the vessel. You made it easy. Now we go only with the culprit, so that makes it much better. But what within your trial, what was the percentage of active devices including Impella?
A very important issue. So we have been criticized that by some people that the rate was relatively low. Altogether, roughly 30% of the patients got any device, including intra-aortic balloon pump. But active devices were used in only roughly 10% of the patients. However, if you look for data, at least registry data from the United States that have been published in 2015, they showed exactly the same rate. Yeah, so what people say, okay, in the United States we are using more active devices, at least based on this registry. That's not true. So currently in the United States you use a little bit more than 30% of patients you are using the intra-aortic balloon pump. Less than 10%, 7 to 8% get an active device, and the rest of the patient does not get any device. So, and we had exactly the same numbers in Culprit shock.
So, and again, there's a paucity of data, I understand, but guide me through, providing to the audience some practical tips. 2018, patient coming with shock, you're dealing with culprit only, no issue there, and just phenomenal work in helping us guide that decision. Which of these patients will you use intra-aortic balloon pump?
So we stopped using the intra-aortic balloon pump based on our
Got
trial.
it.
So, and also in Germany, people are now believing in the trial and in the evidence. So, and maybe it's also because we have different guideline recommendation, at least in Europe. So in Germany, the intra-aortic balloon pump is used in less than 10% of the
So
patients.
which would be those 10 patients, 10%?
At least at my institution, we are
Got
not
it.
using it anymore.
Got it.
Maybe patient with mechanical complications,
Got
which haven't been included into our randomized trials. So whereas still left some recommendation also in the ESC guidelines.
Simple matters, do you do right heart catheterization for patients with shock?
In some circumstances we do it. At least we don't have the data from our randomized trials because we did not recommend it on a routine basis to be done, and we did not collect it in our case report forms. We do it, in particular if I have an inferior MI with relatively good left ventricular ejection fraction. For sure, you have to look what is the reason for the cardiogenic shock. Yeah.
Next two groups, where would you use ECMO?
We are currently using ECMO mainly for patients with severe cardiogenic shock.
Again, lactate level being
lactate level, or maybe also doses of catecholamines. If you're not able to stabilize the patient within in the cath lab. We're also using ECMO for so-called eCPR or ECMO CPR. There's also for sure patients in cardiogenic shock, which is a different group of patients. But this is the situation where we are using ECMO.
Impeller.
Currently, we are using Impeller mainly for high-risk protected PCI, and in some patients where we believe that the cardiogenic shock is not so severe, and then we are using the Impeller. So for us, it's more a staged approach, because ECMO gives you more support, despite having the drawbacks of the ECMO, because we know it increases afterload, and some patients it's still difficult to handle with venting if the patients have no contractility of the left ventricle. So this is an issue which also plays a major role in intensive care medicine.
Last question for you, Holger. Beyond the vessel, the mechanical support, anything else out in the horizon which may be promising for cardiogenic shock?
I would like to say yes, but currently, to be honest, I don't see anything. Yeah, that's a problem. So this is also what people say. So if you look back to the CHOC trial, 1999, we had a mortality in the PCI arm or in the early revascularization arm of 45%. Now, nearly 20 years later, with Culprit shock, mortality is still 45%. Right. So we had no improvement. I don't know why, to be honest. So now we are using stents. We are using drug-eluting stents. Maybe it's also because the patients are getting sicker, they are getting older. This is one thing, and this is what we also observed in our trials. We have more patients with previous resuscitation. And so this is the phase of cardiogenic shock is changing. So formerly it was maybe left ventricular dysfunction or left ventricular failure. Now it's also a disease of post-resuscitation disease, and this is also something where we are not sure how to deal with this situation, because I'm not sure a patient undergoing resuscitation for 10-15 minutes, if you can change the outcome of these patients.
What about, Holger, the association of time? The same patient who's presenting now in profound shock with high lactate levels, what if you were able to get him 1 hour earlier? And that's exactly what is happening in many developing countries, including in India.
Yeah, so this is what we would like to have them earlier, even before they present with cardiogenic shock, just to do early revascularization that you can prevent the development of cardiogenic shock. This is maybe one very, very important issue. Nevertheless, so maybe we need more patient education, that they come in earlier. We also have to develop better systems on patient care and also on treatment. So we have the American Heart Association scientific statement looking for hub and spoke centers, I think this is an important issue also on how to deal with these patients. So treat these patients in dedicated cardiogenic shock centers.
Fantastic. So much to learn from you over the next 2 days, Holger, and a
Thank
pleasure
you.
having you again at Lumen Global.
Thank you for the invitation. Yep.